Hi all, this is Dr. Manish. The topic for today's discussion is fracture healing and its clinical, pathological and radiological aspects. We will not only be discussing about the fracture healing per se and its process, but also the pathological aspects that may hamper or alter the process of fracture healing. We will also delve into how we can modify that process to our benefit by understanding the factors that affect the fractures or the fracture healing pattern and the ways how we can enhance the fracture healing. So the topics basically covered will include basically two parts of it. One will be dealing with the biology of the fracture repair. I tend to call it fracture repair rather than fracture healing because repairing the two ends is the main motto of the Wolff process. Healing automatically comes with any injury. So the process is more likely to be called fracture repair by me many times in this lecture, but it is synonymous with fracture healing. The second part would be dealing with the clinical aspects by which we can enhance this process. Before you proceed with this lecture, I would highly recommend that you should know the anatomy and physiology of the bone as a whole, because these things will be repetitively discussed while we are discussing the whole process, the complex process of fracture healing. Just to recapitulate, fracture healing or fracture repair can come only if there is a fracture. So what is a fracture? A fracture is, as we all know, a break in continuity of the bones. Basically, we see it as a break in continuity of the cortices on a radiograph. It can involve both of them if it is a complete fracture or one of the cortices if it is an incomplete fracture. Sometimes the fracture may not at all be seen. For example, the early stress fractures. Radiologically, they will be silent on a plain radiograph. For them, you have to go for special investigations like bone scan or an MRI. Now, the fracture repair is the immediate consequence of a fracture, unless until the patient is not suffering from syndromic or a genetic disorder, in which fracture healing will not begin per se. Those are the very rare conditions. We are not going to discuss them. We will be focusing ourselves on the repair of this fracture. I call it a unique process. Why unique? Skin also gets injured, but it forms a scar. Muscle also gets injured, it again forms a scar. Nerves, when they heal, hardly they are able to reproduce a nerve. But whenever a fracture heals, it always produces bone, unless until the process is hampered again. But we are not talking of the exceptions. The healing process will lead to formation of bone. That is why it is a unique process. It is a local event which is more or less controlled locally itself. Before we go on to describe the various steps of fracture healing, we should be focusing on two main aspects of the bone, which I have taken from the anatomy of the bone, and they are very pertinent before we understand the process of fracture healing. First of them is the periosteum. In the resting state, we all know it has a fibrous layer. It has a very important cambium layer, which we as a surgeon just take as a potential space to strip off the periosteum. But it contains the pluripotent stem cells that are very important for the formation of an intermediary tissue that will ultimately form bone. These cells supply the bone forming elements for fracture healing. What happens to the periosteum as soon as there is an injury? We see that the periosteum gets lifted away. The wall of the cortex which we saw, the space between the cortex and the lifted off periosteum which we saw was the cambium layer, which contained pluripotent stem cells, gets hypertrophied. It supplies these bone forming cells to repair the bone. These will later form osteoblasts and also the supportive matrix generating cells. Now, what do these pluripotential mesenchymal cells do? They are pluripotent because they form lots of tissues. They can form bone, cartilage, muscle. They can form marrow stroma itself. They can form ligaments, tendons, and other mesenchymal tissues, or even fat cells. Now, because these cells are so disorganized that they can differentiate into any of these, but we want them to be differentiating into bone forming cells. That is why the fracture healing is a very finely regulated process, and there are various factors that help in real production of the bone instead of the other tissues. Second aspect is dealing with the circulation of bone. We know that the bone circulation is a centrifugal circulation. What do we mean by that? There is a high pressure intramedullary nutrient artery system, and then there is a low pressure periosteal articular artery system, which is mainly supplied by the surrounding soft tissues. Because the outer part is low pressure and inner part or the medulla is a high pressure system, the blood mainly flows outside, and inner two-thirds of the cortex is supplied by the high pressure system, whereas outer one-third is supplied by the low pressure periosteal system. When there is a fracture, the intramedullary vessels get disrupted totally. Immediately adjacent to the disrupted medullary supply, this cortex, because it was supplied by the high pressure medullary system, becomes necrotic. If there is no periosteal stripping, then the blood will flow from outside to within the bone, and this will change to a centrifugal circulation. So in a way the circulation is restored, but it is abnormal. It will not lead to formation of a physiologically functioning bone system. It should be very important and very importantly understood that maintenance of circulation again and giving respect to the circulation, blood circulation, is very important for osteogenesis. Now what happens in fracture healing? The intramedullary circulation gets restored, and the intramedullary callus also forms from these intramedullary vessels itself. The vessels also supply the pluripotential stem cells. Now we have learned two places. One was the periosteum that was supplying, the other one is the intramedullary blood vessels. They also supply pluripotential stem cells. There are actually 5 sources. Now the dominance of the extra osseous and the soft tissue supply reduces over a period of time, and there is revascularization of the fractured cortex. If this does not occur, if this process does not occur, the fracture will not heal. This is reiterating the fact that vascularity of the bone is very important in regeneration of the bone. Now we will redefine what a fracture healing is. It is the presence of appropriate cells that will form particular tissues that includes fibrocartilage and bone, and with the activation of appropriate genes and factors. At least 171 genes have been identified that get activated in the process of fracture healing, and the factors responsible are mapped to be somewhere around 96. There are too many of them, no need to learn all of them, but yes, we will remember a few of the important ones. Appropriate cell, appropriate genes and factors should be present and activated at the right time and at correct anatomical location to heal the fracture, to repair the bones. Now this is the real fracture healing. Is it just a single way in which bone can heal? No. The bone can heal in various different ways depending on the type of bone, the location where the fracture is, and there are other variables which are extrinsic to bone, like the treatment variables, the stabilization of the bone, whether the fracture is incomplete or complete, or if it is just a hairline fracture or a displaced fracture. Depending on the severity of the injury and the method of stabilization, the bone can undergo 3 different processes. We as surgeons and as orthopedic students have been very fanatically told that look at the x-ray, this is a displaced fracture, and you see after 3 months when the treatment was done, the bone has healed beautifully with the formation of an intermediary tissue in between, and that is what we rely on as the bone healing. And we often are illusioned by this fact that bone always heals with the presence of that intermediary tissue which will ossify, and then we will tell to the patient that look, your bone has healed because that tissue is now present there. That is not the fact. It is not the most common mechanism, and it is also not the intrinsic pathology or the pathogenesis of a bone repair. The intrinsic method by which a bone would heal is the direct bone healing or direct fracture repair. It is not the indirect fracture repair. Direct fracture repair because it does not need the presence of any intermediary tissue. But these situations are rare if you see a fracture. But these situations are there every time in your body. Whenever we walk, whenever an athlete runs or jumps, there are some minor injuries or micro trauma to the bone which will keep on healing by this method. It is also called by other names called eversion remodeling and all. The second method is creeping substitution. This keeps on occurring in our body since the time of birth till we die, and it is most prominent in the metaphyseal portion of the bone. The most commonly seen or the taught method of fracture healing is the indirect fracture repair that involves the formation of that intermediary tissue which we call callus. Why we call it with a different name, callus? Because this is the tissue which will lead to formation of bone itself. So it is something which is very similar to bone. Although to begin with it is not at all similar to bone, but ultimately it will form into bone and not a scar. That's why it has been given a separate name called callus. And there have been 4 different predominant processes of callus formation which were outlined by McKibbins, but nowadays they have been separated and segregated into discrete types of callus tissue formation. One of them is the intramedullary bridging callus, which is formed from the reforming or the neovascularizing or the vasculogenetic. Now, neovascularization and vasculogenesis are 2 different things, but both of them happen during the fracture repair. From those vessels and the tissue that forms there, the callus forms in the intramedullary region. We call that intramedullary callus. The second is the primary cortical callus, which will form directly from the bone cells which are present in the cortices, and the periosteal callus, which is formed from the pluripotential stem cell that has just now got induced and will form new bone and lay down the bone in an appositional manner. That means they will deposit the bone over the cortex. And the last is the callus formed from the external soft tissues. Now this callus, this is the periosteal, subperiosteal callus. This is the external callus which has come from where? It has come from the muscles. The muscles also contain stem cells. The fat also contains stem cells. So periosteum, vessels, muscles and fat. These 4 things supply pluripotential stem cells to the help of the bone in forming or reforming itself into a continuous bony structure. Where is the 5th element? The 5th element is within the bone marrow. From the bone marrow also you get lots of stem cells which we also use as bone marrow transplant later. So that is the 5th source of pluripotential stem cells. It takes part in the formation of medullary and cortical callus, not the periosteal and the external callus. Now we come to the real phases of bone healing. We are quite interested, and whenever we talk to our fellow people, we keep on asking, do you know how many stages of fracture healing are there? And people would proudly say, I know 4, I know 5, or I may know 6. But actually only 3 different stages were described by Cross-Dumont. And the first one he called inflammatory phase, which I have modified into reactive phase just to easily remember. This is again R phase, reactive, reparative and remodeling. All the 3 starting from R, easier to remember. And because he missed out actually he did not miss out, but he did not describe the hematoma formation which was added by Frost. So people sometimes quote 5 stages of Frost, sometimes they would quote 3 stages of Cross-Dumont, or sometimes they would quote 6. Now how those 6 stages have come? Actually there are 3 stages only. You can divide each of them into 2 subparts, which even I have done for the sake of easier understanding. Now, what the initial injury has done, we will recapitulate. The periosteum, if it has survived, it will supply the bone from outside the blood vessels and the blood supply. Now, this gap is filled with the hematoma, and the periosteum and has hypertrophied now to form bone forming cells. The injured muscle surrounding the soft tissues form a sort of pseudocapsule which will encapsulate the injured part of the bone, and hematoma has filled the gap in between the fractured ends. There is cortical necrosis as we discussed, because the intramedullary blood supply disruption would immediately lead to bone necrosis at the fracture ends. And there are damaged haversian canals in this region, but the haversian canal which are far apart from the fracture site will still contain the bone forming cells. They also have vessels, we should remember, and they will be able to supply the pluripotential stem cells. Now, the first stage, the beginning of the fracture healing, is with the formation of hematoma. Now, hematoma provides the basic tissue. See, cells cannot migrate into vacuum or air. Cells need some milieu or some tissues like structure where they can migrate, home, differentiate, and then form the new tissue what they want to form. Hematoma provides them that substrate. If the hematoma doesn't get organized, the first phase itself will fail and the fracture will be very slow to heal. Now here comes the term called slow union. What is slow union? The slow union does not mean that the fracture is not healing. It will heal, but it is slow to begin with. And the reason is most often loss of fracture hematoma that can occur by the injury itself, if it is an open fracture, or by our intervention. If suppose we operate and during surgery we always have the tendency to evacuate the hematoma which has formed, so the union will be slow to begin with. Now the second phase is the reactive or inflammation phase. It begins immediately after injury. Clinically you see it as pain and swelling, obviously because inflammation begins few hours later, so the pain element is immediately after the trauma may not be that much as it may be after 8 hours or 10 hours. Now that is because the inflammatory cells have come up and cytokines irritate the nerve endings, causing increased pain. It usually lasts till 3 weeks, that is the intense reactive phase, and after that it may last till months, which is a smoldering phase of inflammation. Now, what actually mediates this phase? These are the inflammatory cells, the macrophages, the polymorphonuclear leukocytes, and the T lymphocytes. They secrete the cytokines like interleukin 1, 6, TNF alpha, and COX-2 enzyme is very important for producing this inflammatory phase. If we suppress it using COX-2 inhibitors, it is also going to cause slow union because we are still suppressing the first stage of fracture healing. WNT pathway has been recently propagated and promoted. Actually, it was basically described for maintenance of bone or the remodeling of bone and was relevant in osteoporosis. Now it is also relevant in fracture healing, and it has been found that the inhibitor of this WNT pathway, which is sclerostin, if you inhibit that inhibitor by romosozumab, it will enhance bone healing. And this drug is off-label in use for managing cases that may undergo slow healing. What are the factors mediating the inflammatory phase? Most of these belong to the TGF-beta superfamily. As I discussed, there are at least 96 known factors which have been mapped to fracture healing. We will remember only 4 of them, actually only 3 of them, which is the most important one is the TGF-beta superfamily, which mediates most of the physiological processes in our body. And BMP is a very important component of this TGF-beta superfamily. The other one is alpha-FGF, which is more relevant with respect to renal bone disease and renal osteodystrophy. There you will discuss why the alpha-FGF13 or impellence of this fracture leads to delayed healing and the osteoporosis for generation, actually production in that disease. BDGF, platelets, I call them the wonder cells. They contains factor for each and everything we have learned in the pathology classes. They can generate vessels, fats, even nerves, bones, cartilage, what all and what not. They contain factor for all of them. PDGF is the most important one, which mediates the inflammatory phase. We come to the reparative phase. Now this stage is marked by callus formation. We have discussed it is the intermediary tissue that ultimately leads to the bone formation at the fracture site. There are two predominant types of callus that can be differentiated on a radiograph and histopathologically. First is the soft tissue callus formation when the bone is getting sticky. The ends are getting sticky, but they are not hardened yet. That means the bone still can be displaced because the tissue is quite weak, but it can be deformed. Sorry, it can be deformed. You can still angulate the bone, but you cannot displace it because it is getting sticky. And if it hardens, it forms the hard callus. So soft tissue callus formation is the stage when the bone is sticky. It is deformable, but is not displaceable. And hard callus is the stage when that fibrocartilage soft tissue has mineralized. How this transition is occurring? The fracture hematoma that was present at the break is slowly getting resolved, and the fibroblasts and capillary buds are insinuating into it, migrating through the re-establishment of the intramedullary blood supply. There is mineral deposition which begins at the center of reparative tissue. Why at the center? Usually the center of the tissues are hypovascular, but here the situation is different. The blood supply is getting restored from the intramedullary region, and because of the restoration there, the mineralization front is also very active at the hypervascular site compared to the hypovascular peripheries, where the cartilage tissue is much more formed. Cartilage forms in the places where there is lesser oxygen tension because of lower blood supply. Now here we can see that in a soft tissue callus or soft callus, there is appositional bone formation. Yes, the bone forms in soft callus also, but it cannot be seen on a radiograph because it has not mineralized. The bone is there, which is getting developed from the subperiosteal osteoblastic cells that have formed. The peripheral hypovascular region that contains lesser amount of oxygen contains a lot of cartilage. See these cartilage cells which are developing here. The central portion contains bone also because this is hypervascular, relatively hypervascular compared to the peripheral part. Now this soft callus mainly comprises of fibrocartilaginous tissue. It starts forming with the ending of inflammation or the intense phase of inflammation, which was 3 weeks, and it continues till up to 3 months, but in between there is mineralization also. So hard callus also starts beginning by around 2 months of this when the soft callus phase is continuing. The hard callus begins with the point of initial stability. Stability will be gained when that soft friable tissue was getting organized into mineralized tissue. So the deformable but not displaceable bone will form a not deformable and not displaceable bone. So now the both things cannot be done when the tissue has mineralized and formed irregular new bone, which we call woven bone. This is still the immature bone. See the cortex, which is organized into concentric circular Haversian system. This bone is very immature and is basically has to be changed. It has to be changed. But here is what the surgeons usually sort of mislead themselves and also the patient, saying that the bone has united. The bone may have formed a new bone, but it is not completely united. This phase would last till 6 months, and you will show the patient on the X-ray also that look, the bone ends are now filled. In between the radiolucent region of the bone end is again filled with a white tissue. We call this bone, and the bone is united. You can continue all your activities. It is partially correct, but still we should be telling the patient like you have to still take care because the new bone which has formed is immature and still weak, but it is radiologically seen as union. Whenever you see hard callus, you call it radiologically as united fracture, and the activities would depend on type of fracture and the type of activities desired after that. The mineralization of fracture callus needs type 1 collagen for deposition of calcium hydroxyapatite crystals. Till stage of soft callus formation, the collagen was predominantly type 2 collagen. I deliberately did not describe it there because we have to understand the difference between these two collagens. Type 1 collagen has pores that can hold the basic calcium phosphate, basic and acidic. That is the basic word used here. The basic calcium hydroxyapatite crystals can be fitted in those pores which are found in type 1 collagen. Type 2 collagen does not contain pores for insinuation of these calcium hydroxyapatite mineral crystals. It has proteoglycans in it, and those proteoglycans are hygroscopic molecules that maintain the hydration. So that collagen is good for cartilage. Type 2 is for cartilage, type 1 is for bone. Bone, B-O-N-E is the spelling, O-N-E is 1. So always remember, bone contains type 1 collagen. How is it deposited? There is increased activity of alkaline phosphatase around that tissue which has formed, and there is essentially degradation of the proteoglycan by endopeptidase. If the proteoglycan is not degraded, this mineral will not deposit, and even with the presence of type 1 collagen, the bone or the hard callus will not form. The stage at soft tissue or soft callus itself will arrest, and if that state persists, then it will lead to hypertrophic non-union formation. Now, what are the mediators of this callus or the reparative phase? Typically it is the protein synthesis, which is done by lots of factors mediated by TGF beta superfamily and PDGF. Platelets now brings in other factors also, VEGF, FGF, EGF, and all factors that help in lot of protein synthesis by the cartilage forming cells or the chondroblasts, and later by the osteoblasts also, and then mineralization of that front by alkaline phosphatase. Alteration of the tissue from collagen 2 to collagen 1 is brought about by chondroclasts, just like osteoclasts which degrade the bone matrix. Chondroclasts degrade the cartilage matrix, and that type 2 collagen is changed from type 2 to type 1. Now it's the revision time. We have discussed till now 4 sub-stages of the 2 main stages. The first was the formation of fibrin clot, which led to formation of loose fibrous tissue, and what we call that? We called it the soft callus. Then this soft callus matured into hyaline cartilage. Initially there was only fibrous tissue, then there was cartilage tissue and cartilage present along with type 2 collagen. Both of these comprised of the soft callus stage. Then that got mineralized by formation of type 1 collagen, alkaline phosphatase, and increase in the bone specific proteins like calmodulin and osteoporins. Now we should remember that this is a very finely managed sequence. If it arrests at stage 1, we will get slow union or no union, or the atrophic type of non-union. If it arrests at soft callus stage, we would get hypertrophic callus formation. It slowly mineralizes, and if the arrest is between this type 2 to type 1 transition, we get elephant foot type hypertrophic non-union. If we get arrest at within the soft callus formation, then we get horse hoof type hypertrophic non-unions. We already discussed that the bone that formed during the hard callus stage was immature. It was the woven bone, so it has to be changed and converted into mature looking bone. The structure of a bone, or the cortical bone, is the Haversian system that typifies the cortical bone, and even the cancellous bone has fine trabeculations. It has that woven bone did not contain any of these. It was the irregularly organized trabeculae which were just running here and there. It did not have the requisite strength also, and also it did not have the requisite amount of vascularity to flow through the bone. So the bone has to be modeled in the shape again to regain the strength and its function. Now that regaining that model is called modeling, but over a period of time, somehow the word remodeling has creeped into orthopedics, so much so that now this term has replaced the original correct term modeling. I am really a big fan of the word modeling, but because so many people have described this stage as remodeling stage, so I have retained the word. It is the change from woven bone to lamellar bone, and the bone models itself to the original structure. It can persist for many years. If suppose the fracture has occurred in the late 40s or 50s, then it may persist till their lifetime, that this phase. In children, the remodeling is very fast to occur, and then they may model their bone within 1 year. Remodeling, originally this word described the calcium phosphate metabolism, which keeps on occurring within the bone throughout the life, and that is what was remodeling. But nowadays we describe remodeling as the third stage of the fracture repair. What manages or what brings about this remodeling phase? It is the osteoclastic activity. Too much of the callus was deposited at the site, which was not required actually. So it has to be degraded and resorbed, and that wasteful callus is resorbed by osteoclastic activity. It also resolves the disorganized or unorganized trabeculae. But how? How would osteoclast know that this particular trabeculae is not needed and the other one is needed? That is dependent on the mechanical forces to which the bone is subjected in all day-to-day activities. So the bone is formed along the lines of stress, and that is what we call as and understand as Wolff's law. Now this Wolff's law tells us that bone form follows function. Bone form means the bone structure follows the function. Now what is the function? Bearing the tensile and the compressive stress. So all those stresses will guide where the trabeculae should be present and where they should not be. All the negative things in this world are not really negative. This is my favorite phase whenever I teach people, that the electronegative part of the bone has the osteoblastic activity. Here is the most of the bone that gets deposited. Now consider two parallel lines and equal charges distributed along them. If I bend those two parallel lines, the part which has become convex will have charges distributed apart from each other. They are rarefied. Whereas the concave part will have crowded charges together. And usually the charges are hydroxyl ions, OH ions. So hydroxyl ions are OH negative, they are negatively charged. Those negatively charged ions make that concave part of the bone or electronegative, and they are important also in deposition of bone, and they activate the osteoblastic activity. This is how Wolff's law, by altering the bone structure, by bending the bone, would lead to resorption of the bone on the electropositive side, whereas deposition of bone on the electronegative side. That is how the new trabeculae will be formed here, and the trabeculae will get resolved from the electropositive or the convex side. Now, mechanobiologics play a very important role in remodeling phase, and this was emphasized by Powell, who told that if there is excessive deformation, if there is lot of shear, or the horizontal strain, or even the compressive strain, then the bone will not form, it will remain a connective tissue. If there is excessive compression, the hyaline cartilage gets crushed and again the bone will not form. So we need to have a balanced mechanical stimulus to the bone in the form of usually cyclic loading that helps in bone formation. This was again emphasized, and the whole complex situation was curtailed down to just the strain by Perrin. He is told that if there is a strain which is less than 2%, that means the change in length is less than 2% of the original length, then bone will form. Otherwise, either it will arrest at the soft callus stage, the fibrocartilaginous tissue when it was formed, or at the granulation tissue itself. Now, the granulation tissue which was present in the inflammatory phase, hematoma, inflammation, soft callus, hard callus. So at the inflammation stage, the granulation tissue which was formed can bear the maximum amount of translatory strain. And if the strain is not controlled, then only that tissue will survive. Rest everything will not form. Neither the vessels will form, neither the cartilage will form, nor the bone will form. So if there is excessive strain, there will be complete non-union. If there is reasonable amount of strain which can be still later on changed, so the bone will show arrest at fibrocartilage tissue formation, and here we call it a delayed union. So if you see a delayed union, that means you have to modify this strain from the 10 to 2% range to less than 2% range. That is why for delayed union, for example, if you see a delayed union after a intermedullary nailing in femur, we understand that the strain is between 10 to 2%. So there is callus formation, but it is not bridging the fracture. So you have to increase the stability. If you increase the stability, the strain will go less than 2% and you will see that the bone has healed. This is the principle how we find delayed union, and then we try to improve the mechanics or mechanobiology there. You can also dynamize the nail. That will lead to compression and approximation of the fracture ends, which due to friction and load bearing will stop translatory strain. So again the fracture would heal. This is the reason why we do dynamization at this stage. What are the biological mediators of remodeling? Lots and lots of drugs are acting during this stage, and we should be knowing that if you give osteoclast inhibitor like denosumab, it will lead to it will reduce the remodeling potential. Bisphosphonates also do the same thing, but it has been seen that when you institute bisphosphonates with fracture, there is increased callus volume. Although the callus volume is much more, but we have discussed that this callus or the bone that has formed is immature and woven bone. This is not what we want. We want a mature bone formation. So we should try to restrict even the bisphosphonates during this state. Estrogen and progesterone, both of them enhance bone healing, but they are not used for this purpose specifically. Strontium granulate can be given for delayed unions, but there is no off-label or on-label indication of this. It is a very good compound which has two ways of action. It inhibits the osteoclast and it also induces or activates the osteoblasts. So it may help in more or the better bone formation if there is some delay in fracture repair or fracture healing. But the primary indication of strontium is still in osteoporosis. Parathormone is although parathormone stimulates osteoclast, but it has been found that pulsatile form of this hormone, if given till 4 months, may improve bone quality and bone quantity. So increased amount of bone has been seen. It has been off-label used in typically patients who have osteoporotic fractures, where it serves both the purpose. It treats the osteoporosis also, and it also helps in union in elderly patients, where we know because with age the healing potential reduces a bit. Now this was the whole rhythmic process of fracture healing. Initial inflammatory phase lasting for up to 3 weeks. Then there was soft callus formation which lasted till 3 months. In between the hard callus stage started, and the mineralization of this soft callus led to radiographic union of bone still with immature bone, and that remodeled into mature bone. Minimum 1 year is needed for remodeling, but it may persist for whole of the life. Now we have discussed the indirect bone formation. We left out two different forms of bone healing, and they are very important. First one is direct bone healing, and I told and discussed that this is the most common mechanism of healing of bone in our body. This involves only one type of tissue formation. Indirect bone healing had two tissue formed. If you remember, it was a fibrocartilage. So there was both intramembranous and endochondral ossification involved in indirect bone healing through callus formation. But in direct bone healing, it is only the intramembranous tissue which forms and it directly heals into bone. There are two methods in which direct bone healing can occur. The first one is osteonal remodeling. Osteons are the concentric circular canals which we call the Haversian canals. They can directly go across the fracture through a particular mechanism. We call it the cutting cones. I call them cutting bullets because they look more like bullets rather than cones, but they will occur if there is gap less than 400 micrometer. As you can see in this radiograph here, the fracture line is also not visible because of this interfragmentary screw. That means the bone ends have so well coapted together that there is literally no space that can be seen. And if there is a normal remodeling process, the cutting cones keep on forming bone, and that is the remodeling which keeps on occurring in our body. And those cones will go from one part, one fragment to the other, as if the fracture did not ever exist. Now this is the most ideal situation for bone healing to occur, and this keeps on occurring in our body whenever we walk or jump or run and cause micro trauma to our bone. The other one is called gap healing, when the gap is more than 500 micrometer. You can see in the same X-ray there are some very finely visible gaps. These gaps are very rigidly mobilized by this fixation method, and there will be minimal strain. This space will be occupied by the fibrous tissue, and that will directly ossify into bone without formation of cartilage in between. These are the cutting cones which I was describing. Now this is more or less a bullet shape which is led by osteoclasts. They leave a space or gap in between which is revascularized by the vessels. Now we know vessels supply pluripotent stem cells, and these stem cells will form these osteoblasts, and they will lay down the bone on the walls of this bullet in the form of new appositional bone. This is the new bone being laid out, and this is the front which is going on. It is going across this fracture as if there was no gap in between. Now the osteoclasts resorb the bone. There is medullary revascularization in between, and osteoblasts lay down the new bone in a positional manner. The last one is the creeping substitution, where there is resorption of these trabeculae. They also occur by osteoclasts. They stick on the surface, resorb the bone, but they don't degrade the collagen matrix, and that matrix is reformed by the osteoblasts. Usually the osteoclastic activity exceeds that of osteoblastic activity after the age of 30 years. Till the age of 30 years, this was reverse. The osteoclastic activity was lesser than the osteoblastic activity. So, larger amount of bone was being formed. So, during our growth phase, whenever we are under the influence of growth hormones, thyroid hormones, and the newly developing testosterone, the gonadal hormones, and the steroidal hormones, increased amount of bone will be formed. The trabeculae will get thickened because the osteoblasts are much more active than the osteoclasts. When the osteoclasts become more active with age, when the testosterone levels go down and also the thyroid levels go down, then the osteoclastic activity predominates, and these trabeculae will get thinned out. These things keep on happening throughout our body, throughout our life, predominantly in the metaphyseal bone, through the process of creeping substitution. This is called creeping substitution. Why? The same part is being substituted again by bone, and because of the creeping tissue that creeps into that trabeculae. This is the way how the cancellous bone graft will also heal. This is also the way periarticular fractures, where predominantly there is cancellous bone, they will also heal by creeping substitution. So depending on the type of bone, in a nutshell we can say that depending on the type of bone, this natural unique complex process will modify itself. It may heal by creeping substitution, for example in the metaphyseal cancellous bones. It may heal by endochondral and intramembranous combined tissue formation, which we call callus, and that predominates in displaced fractures. If the fracture is very meticulously reduced, or if it is an undisplaced fracture, it may heal by primary bone union. That may be a gap healing, or that may be a osteonal remodeling. The sequence is to be borne in mind whenever we prescribe a treatment, whether it is plaster cast or plating or nailing. We should know what type of healing will this bone incur, if I do whatever the intervention which I have planned. So it should be optimal for a patient. And fracture healing in same bone may involve different mechanisms as we have discussed. It may heal by indirect mechanism, indirect bone healing, or the direct bone repair. There are lots of factors. All these 6 stages which we discussed, all these stages are modified by lots of variables. They start from the injury itself, the treatment, the patient factors, how old is he, what is the nutrition status, etc. They have to be understood and borne in mind before we ever institute the treatment for proper healing, and we should be able to control this milieu to provide the best optimal outcome to the patient. So this was the learning of fracture healing in a nutshell. We will continue with the factors that affect the bone healing, and we will also clinically exploit those factors combined with our understanding of bone healing which we have learned just now to provide the best outcome for patients in which the fracture healing has somehow derailed. Thank you.